Good afternoon, everyone, and welcome. Welcome to today's webinar, and thank you for joining us. My name is Henry Shelton Brown. I go by Shelton, and I'm an Associate Professor of Management Policy and Community Health at the UTHealth School of Public Health, Austin campus. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UTHealth School of Public Health in Austin. The center's vision is healthy children in a healthy world. Before we get started, I just wanted to make some housekeeping announcements. One, the webinar is being recorded and it will be archived along with the presentation slides at our website, msdcenter.org. That's msdcenter.org. And if you have any questions during the presentation, please enter them in the question box. We'll have a time for Q&A at the end of the presentation. Okay, thirdly, the MSD Center has many resources that you can access by scanning the QR code on the screen. Now I'm excited to introduce our speakers today, myself, Sierra Castedo de Martell, and Marnie Moore. Sierra and Marnie are doctoral candidates and graduate students here at the UTHealth School of Public Health Austin campus. I will now hand it over to Sierra to begin our presentation entitled Cost Effectiveness Calculators for SUD, a pilot of peer recovery support services and bystander naloxone distribution.
Thanks so much, Dr. Brown, and I'm actually going to let my colleague Marnie introduce herself briefly before we move on.
Hi, excited to talk to y'all today. I'm Marnie Moore.
Great, all right. Well, I'm Sierra Castedo de Martell, and I will be leading you through the bulk of the presentation today. I do want to pause and acknowledge a couple of folks who are not here today, and one is our co-author, Hannah Wang, who is a programmer analyst in the Information Technology Department here at UTHealth, who was responsible for the web-based interface for our calculator. And I also want to acknowledge our funder, the Recovery Research Institute. It's a NIDA pilot grant funding mechanism that goes through the Recovery Research Institute. And the pilot grant is to advance research on recovery community centers nationwide. Sorry, having just a little bit of trouble with the advance slides function here. All right, and these are the Michael and Susan Dell Center resources. And let me just give you a little bit of an outline for where we're hoping to go today. So our ultimate goal we're going to talk about in just a moment, as well as give you some background information. Then I'm going to introduce you to a little bit about what cost effectiveness analysis is, how we might use it, how we structured our specific analysis to make the calculator tools, and then we will give you a hands-on tutorial with our cost effectiveness calculator. And we really encourage your feedback during that portion. Okay, there we go. So our ultimate goal is to have a free web-based, multifaceted cost effectiveness calculator that would empower stakeholders, including recovery community organizations, advocates, community decision makers, et cetera, to use cost effectiveness information in order to both increase support for existing programs, maybe to increase funding or to encourage the maintenance of these programs, or to build support for the adoption of new programs in places where they don't already exist. Kind of as a bonus, we also would help fill in some of the knowledge gaps. There's very few economic evaluations of peer-driven recovery infrastructure in the substance use disorder space. So kind of as a bonus, we have this academic goal as well. But reaching that ultimate goal of a multifaceted calculator would take a lot of work. So we have taken the approach of sort of tackling a piece at a time. We started back a few years ago with my master's of public health thesis work on a collegiate recovery program cost effectiveness calculator. So that was kind of our first foray into this substance use space. That one is Excel based. It's available at the link. It's not pretty. The ones that we're going to show you today are certainly a little bit more user friendly. And we secured pilot funding through the Recovery Research Institute's pilot grant program to fund what we're going to show you today. And this calculator includes two components. One component that looks at long-term peer recovery support services, that's this acronym PRSS, and bystander naloxone distribution. And then that funding also allowed us to turn it into a free web-based calculator that's a lot more accessible. It's passed ADA compliance testing, and something that's web-based and not based in Excel is just a little bit easier to use. We're also going to seek peer-reviewed publication of the underlying analyses that we use to build the calculators. Although the bystander naloxone distribution component is based on previous work by Coffin and Sullivan, 2013, we've just updated it. All right, here's a brief timeline of what we did to get here today and where we're going. So we got that pilot funding. Then Marnie Moore and I tackled the background research for each of our components. Marnie took the lead on bystander naloxone distribution, updating that Coffin and Sullivan paper, and turning it into a something that we could use for a calculator. And I took the lead on the PRSS portion. Once we had an idea of how we were going to model cost effectiveness for both interventions, we then took our overview of those models to two local recovery community organizations, the exact kinds of organizations that would be implementing these kinds of programs. And those two organizations, we'd like to give them a huge thank you, are Communities for Recovery and Recovery ATX. So they reviewed the model. We taught them a little bit about how cost effectiveness works and why we might want to use it. So they had that context for understanding the models. And then we incorporated their feedback into a prototype calculator that we worked with Hannah to build on a web-based interface. We then took that prototype back to the RCOs, the recovery community organizations, to test out the calculator, make sure it worked the way that we hoped that it would work, make sure that the inputs that we requested from the recovery community organizations were things that they could easily gather, things that made sense to them. We then took that feedback from that meeting and Hannah integrated it into a final pilot calculator that we then presented for the first time at the National Association of Peer Supporters, that's NAPS, conference that just happened this past Thursday. It's a conference for peer professionals delivering both mental health and substance use disorder peer services. And then we're also presenting today on this webinar for a much broader audience. We gathered feedback at the NAPS presentation, and we would really love to gather your feedback as well. You'll have a link to a survey at the end of this presentation and after viewing the calculator. And then we're going to integrate that feedback into future improvements, adding on additional components to the calculator, but then also just improving the tool as it stands right now as well. Okay. So that brings us up to today and kind of lets you know where we're going. Next, we're going to talk a bit about what cost effectiveness analysis is, how it works, why we might be interested in it, and that'll give you some context for how we structured our analysis and kind of why we made the decisions that we made in the structuring. So let's dive in. So cost effectiveness analysis is just one of many types of economic evaluation. Economic evaluation might also be called efficiency evaluation. And it's called efficiency because we are thinking about kind of this flow. So we have resources that go in to make some kind of intervention happen. Then we have our intervention, which might be some kind of program or some kind of activity. And then we have the good stuff that comes out of an intervention. And that good stuff might have a lot of different forms. We might measure that a lot of different ways. But fundamentally, when we are doing some kind of economic or efficiency evaluation, we're asking questions about how balanced these two pieces are. How balanced are resources to the good stuff produced by an intervention? And cost effectiveness analysis is just one of many types. You may have heard of these other two types. I feel like these are more recognizable terms by the general public. So you may have heard the term cost benefit analysis or return on investment. But some key differences are that in cost effectiveness analysis, we actually don't have to put a dollar value on that one side of the equation, the good stuff side of the equation. But in these other types of economic evaluation, we do. We put a dollar value both on the resources side of the balance beam and on the good stuff side of the balance beam. And that can be a little bit tricky, especially in an area like substance use disorder recovery, because there's been a ton of evolution happening around what it means to be in recovery, how we even go about measuring that. We used to have kind of really straightforward definitions around, well, recovery is obviously pure abstinence from all substances, but those kinds of definitions are changing. And so translating that into some kind of dollar value can be really tricky. And frankly, to many people who work in this space, it can feel a little bit icky. And if we're designing a tool that we want people to use who work in this space, we want it to benefit their work, then we want to make sure that it's something that captures the values of the people doing this work, in addition to demonstrating the value of this work, right? So for that reason, we decided to move ahead with cost effectiveness analysis. We kind of sidestepped some of those issues around putting a dollar value on the good stuff, and it makes things a little bit more straightforward and a little bit more flexible when working in kind of this evolving field where the outcomes are definitely in a state of flux right now. Okay, so there's a lot going on this slide. We're going to break it down piece by piece, and I'm going to give you a metaphor that should hopefully help you understand this a little bit. So we're going to look at this, and then we're going to come back to it again. So in cost effectiveness, we get an end result that is called an incremental cost effectiveness ratio, or ICER. And we get that from this basic cost effectiveness formula. We are finding the difference between the cost of the intervention, the cost of kind of our standard comparator, and the effects produced by both. And that gives us our ICER. That is telling us, the ICER is telling us the price of the intervention for every unit of good stuff that the intervention produces. And so our results will be things like $100 per person who quit tobacco, or $20 per sick day that we avert, or $500 per quality adjusted year of life added. And that can sound a little bit funky, but here is an everyday example that may help you think about it a little bit more clearly. And that's the grocery store. So in the grocery store, we can compare sticker prices. But packaging or product size or the products themselves might not be identical. So we can compare instead the price per ounce or the price per some other unit instead. So let's think about cereal, right? We have a million different kinds of cereal. We have bags, we have boxes, we have little pouches. So it can be difficult to compare different types of cereal. Let's say I'm trying to decide between this box of Cheerios that is 15 ounces and this box of Oat brand cereal that's generic, that's 12 ounces. Well, from sticker price alone, sure, the Oat brand cereal looks cheaper, but it's also smaller. So how can I be sure that I'm actually getting the best deal or making the most efficient use of my money, maximizing the amount of breakfast that I can get with every dollar? Well, I look at the price per ounce instead. And yes, indeed, that Oat brand cereal still wins. It's only 20 cents per ounce compared to the Cheerios, which are 26 cents per ounce. Now, we can also look at exactly the same product and exactly the same brand, but look at different sizes. And when we do this with economic evaluation, we might call that looking at economies of scale, seeing if there's economies of scale there. So I might assume that a 44.5 ounce bottle of Hunt's ketchup is going to be a better deal than the 35 ounce bottle of Hunt's ketchup, because often, you know, bigger bulk, it's cheaper, right? But if I look at the price per ounce, I see that I'm actually getting a better deal if I go with a smaller bottle of ketchup. And similarly, when it comes to interventions, when it comes to public health interventions, sometimes they don't scale up efficiently. We might assume that a larger intervention is going to run more smoothly, it's going to have more capacity, but that's not always the case, right? Sometimes it isn't efficient at certain scales, but it's efficient at a smaller scale instead. So cost effectiveness analysis is really cool because it can help us compare things that are pretty different, but it can also help us look at the same intervention, but just at different scales as well. Okay, so let's go back to that slide that we were on before the serial example that was maybe a little bit confusing or a lot of information. So hopefully with that context, we can read these example results with a little bit better understanding of what they mean, right? So instead of price per ounce, we're thinking about price per unit of good stuff. So that $100 per person quitting tobacco, or $20 per averted sick day, or $500 per quality adjusted life year added maybe makes a little bit more sense now. Okay, and then let's look at this treatment as usual part of our cost effectiveness equation. So we always want to compare the intervention that we're looking at to the current standard of care. So that's often called treatment as usual. It might be, you know, something like an old vaccine that was already in use and already worked pretty well, but we're testing it against a new vaccine to see if it's more efficient, to see if it's more cost effective than the old vaccine. But we also, you know, it might be something else, like in our case with peer recovery support services, it might actually be substance use disorder treatment, right? So the word treatment might be pretty literal, or it might be something that's a little bit more abstract to interpret. Next, we're going to take a look at the bottom part of this equation, the effects, the good stuff that comes out of our intervention. So remember, we don't assign a dollar value to this effects part. And we always want to at least start with quality adjusted life years, or QALYs. Now let's talk more about what QALYs are. I know many of you in the audience have heard that term. I know it's a big public health audience today, but just so everybody's on the same page, let's say my intervention adds 4 years of life expectancy per person. Awesome. But let's say that my intervention is actually also really tough on people, and you know, maybe it has a lot of side effects, maybe it's really rigorous and really difficult to get through, and so it gives people 4 extra years of life. But let's say those years of life are maybe half as good. Their quality of life is about half. So to actually apply that, we would multiply 4 years of life by half, and we would get 2. So we'd get 2 QALYs added. So that's this bottom example here. But let's say my intervention adds 4 years of life, and the people who participate, who get the intervention, are in perfect health, you know, 0 complaints whatsoever. Well, then we would say that's 4 QALYs added. We just multiply 4 by 1, which means perfect health. So QALYs are actually a lot like that ketchup example, or I'm sorry, the cereal example that we just gave. It allows us to compare different types of cereal by the price per ounce. So QALYs allows us to compare lung transplantation to HPV vaccination screening, right? Or sorry, HPV screening. Those are very different types of interventions, but if we're looking at the cost per QALY, then we have a grounds for comparison, right? We're kind of reducing each intervention to terms of QALYs, right? Okay, so we always want to start with QALYs, but we don't want to end there. We also always should do something, measure something that's useful to stakeholders and useful to the people who can use this information the most. So we might think about things like, maybe additional person in recovery because of this intervention, somebody who, would not have been in recovery if they were a part of more traditional or standard interventions. Maybe we do it in terms of lives saved. In some of the examples I gave earlier, it was per person quitting tobacco, additional days that somebody's not sick, right? So we want something that's meaningful as well, something that makes sense in the context of that intervention, and that's going to be interpretable to the people who are going to consume this information, right? Okay. So now we're going to move up to the top part of our cost effectiveness equation. So we've got the costs of the intervention and the costs of treatment as usual. We always want to look at least two perspectives. The first is societal. We are thinking about all of society here. It's a pretty broad view. So we want to think about, if people are getting this health intervention, how much of their time is being taken up when they could be doing other stuff with that time. We are thinking about medical costs, yes, but we're also thinking about, maybe effects that it might have on work, maybe criminal justice effects, maybe family and home effects, parenting, education, just kind of globally, what's going on. We also want to look at a narrower view. We call that the health system perspective, and it's actually pretty flexible, even though health system, sounds like it might just mean medical care, right? The health system could be something like all of Texas Medicaid or like the whole US healthcare system, but it could also be something like a college campus. For the cost effectiveness calculator of collegiate recovery programs, that kind of our first foray into this realm, we used a college campus as the health system perspective because a lot of college campuses are kind of providing health services to their students, especially in the realm of substance use. So we're just narrowing down to things like medical costs, things that would kind of be contained within whatever that system is. We're not looking at stuff outside of that, like the participant time or employment or criminal justice or anything like that. So let's recap briefly. We have no dollar value assigned to our effects. We need to look at least quality adjusted life years and ideally one other thing that's meaningful, maybe a few other things, but at least one other thing that's meaningful within the context of that intervention. So that's our effects side. And then for our costs, of course, it's costs. We're assigning a dollar value to everything. And we are also looking at least two perspectives, the societal perspective and the health system perspective. And that means we're going to have at least two ICERs, potentially four, right? So let's talk about how to interpret ICER. So once we have an ICER, it might look like just one number. Remember, it might be a result like $10,000. But remember, that's a ratio. So it's actually over one unit of good stuff. So we read it and we interpret it as $10,000 per quality adjusted life year or $10,000 per additional person in recovery. So what does that actually mean though? So we want to not look at that just in isolation. We want to compare it to a willingness to pay threshold. It's standard to use these thresholds right here, $50,000, $100,000, and $200,000 per quality. The history of this number actually starts with the 50,000. That's what dialysis used to cost for every year of life it added. But that was way back in the 70s. So we've got to adjust for inflation. So people also like to use that $100,000 or $200,000 willingness to pay threshold. But again, here, we also want to use some number that is contextually meaningful. So in our case, we landed on something that's meaningful within the SUD context. So maybe the average cost of specialty substance use disorder treatment, or maybe it's the cost of another visit to an emergency department or ICU. We could also compare to ICERs of other interventions, but in the peer-driven behavioral health world, there's not a lot of studies to compare ICERs to when it comes to these peer-driven interventions. Remember, we have a big gap in the knowledge base right now. So once you have decided what those willingness to pay thresholds are going to be, if the ICER is less than that, if it's less than any of those, it's cost effective. Congratulations. It can also be cost effective to some thresholds, but not to others. So let's say it's cost effective to the $50,000 threshold, and then of course to the ones above that, right? But maybe it's not cost effective compared to the cost of an episode of ICU care. Maybe that's $10,000, and it is right in between those two. If an ICER is negative, sometimes that's good and it means it's both cost saving and cost effective. But the ICER has to be negative because it costs less and is more effective. So if this top number here is negative, the intervention costs less, so that top number is negative. And if the denominator, the bottom number, is positive, intervention does more good, so it's positive. That's going to give us the good kind of negative ICER, right? If it is a negative ICER because it costs more but produces less good stuff, well, then that's not so good, is it? So we want to make sure it's the right kind of negative ICER, but generally speaking, negative ICERs are nice to see. It means it's both cost saving and cost effective, and that's really nice. But remember, it does not have to be cost saving. It does not have to be negative in order to be cost effective. Positive numbers are totally fine as long as they're below our willingness to pay thresholds. So sometimes when we are putting together our models, we are dealing with some uncertainty. Actually, most of the time, we're going to be dealing with some uncertainty. We may have different results across different studies that we're kind of trying to put together. We may have variation across geography. So we want to be able to look at that variation. For the calculator does this the best. It does the base case. The base case is when we're just looking at our basic model for a set period of time. We're not looking at any uncertainty. We're just looking at, maybe the average or a median number that we've plugged in. Then we have one-way sensitivity analyses. That's when we can change one variable at a time through the full range of variation to see how the ICER is affected. So if I add participants, how does that change ICER? If I pay a peer worker more to deliver the intervention, how does that change ICER? We can do this with a calculator, but we can do this with our calculator that we're going to show you today, but it's not going to do it automatically for you. You'd need to do that by hand, just changing one variable of interest at a time and then writing your results down somewhere to compare. In a full evaluation or for academic papers, we will also do a multi-way or probabilistic sensitivity analysis. That's where we look at all variation all at once. And we look at what's the chance that any given intervention would be cost effective. The calculator absolutely cannot do this last one. We will include that in a future academic paper for peer recovery support services, and there should be one in the naloxone study as well already. Okay, so that is all the background on cost effectiveness, generally speaking. So we're all on the same page now. Now we are ready to talk very specifically about how we structured our analysis to make the calculator. And then we will move into getting some hands-on time to work with the calculator after we give you the specifics of our model. So I am actually going to turn things over to Marnie first. She's going to walk us through the bystander naloxone distribution portion of the model. Marnie.
Thank you, Sierra. One more slide, I think. There we go. So for the bystander naloxone distribution program, The population that we're examining is everyone who uses opioids, not just people who have opioid use disorder. For those who use opioids, they can either have a naloxone kit present or not. Based on our research, it appears to be accurate to assume that there's about 20% of people who use opioids have a naloxone kit present. And that's due to the practice, which is becoming more common, of when a prescription is written for opioids, there's an accompanying prescription for naloxone to be kept at that person's home. So for those who have a naloxone kit present, there are 3 potential outcomes. And for those who don't have a naloxone kit present, there are 3 potential outcomes. Those who use opioids and don't overdose, those who overdose and survive, and then those who overdose and don't survive. So either all 3 potential outcomes, whether naloxone is present or not. Next slide, please. So here's the equation that you've just been hearing Sierra talk about how it's created. There's a number of parameters to consider when we talk about bystander naloxone, and this is just in its simplest form what we've said. And so the numerator is the cost of the naloxone kit plus the medical costs that are associated with naloxone being administered minus the medical costs if no naloxone is administered by a bystander. In many cases, naloxone is probably on both sides of that numerator because it's either administered by a bystander or it's administered by a paramedic or an emergency room doctor. But part of the difference in, so the main part of the difference in the numerator that we're looking at is actually the difference in medical costs. It is becoming more and more common for people revived by naloxone to refuse transport to a hospital. And so that's part of it. It changes the overall medical costs if they're revived in the field or at home by somebody who has naloxone present. The primary difference, though, in the equation is in the denominator for naloxone, and that is because of the number of lives saved due to a bystander naloxone program. Next slide. So their costs, this equation only looks at the health system costs. But again, for naloxone distribution programs, one of the most significant factors, actually the most significant factor when we're talking about this from a societal perspective, is the number of lives saved. Bystander naloxone administration is found to be incredibly effective in reversing overdoses and in saving lives. That's the equation. Thank you, Sierra.
Thank you, Marnie. Okay, so I am going to talk you through similarly how we structured the calculator for peer recovery support services. So much like in bystander naloxone distribution, we have this kind of same branching structure. The difference is that we are starting out our assumption with kind of a smaller population. And here's why. If you think about it, the standard care for substance use disorder is actually nothing at all. In any given year, this is information from the National Survey on Drug Use and Health, about 95% of people with a substance use disorder get nothing, no treatment, not a doctor's visit, not a chat with a friend, not a drop into a free community support group meeting, nothing, right? And there's a lot of reasons for that. A big part of the reason is actually problem recognition, and that's fine, right? So to set some of those issues aside and to give a much fairer comparison to what maybe the standard of care is, so it's the standard of care, but people don't standardly actually get it, right? So we wanted to make that a fairer comparison and compare to what kind of the best case scenario is, right? So we decided to set this up as the starting point being people who get specialty substance use disorder treatment. So specialty substance use disorder treatment is inpatient or outpatient treatment that is dedicated to substance use disorder. So it's distinct from something like visiting the emergency department one time after an overdose, right? That wouldn't qualify as specialty substance use disorder treatment, nor would going to a couple of free informal community support group meetings, right? It would be some formal treatment. So that's our starting population. And we know that not everybody gets that, but that allows us to make a fairer comparison than to the real standard, which is nothing, right? So after specialty treatment, in our simulation, people can either not go on to get long-term peer recovery support services after treatment, or they can get 1 year of peer recovery support services after treatment. And then the outcomes of that, some percent are going to stay in recovery after getting treatment, right? Treatment is effective. So even in the non-PRSS portion, there's going to be some percent who stay in recovery. There's going to be some percent who return to chaotic substance use disorder, and then there's going to be some percent who die, either from, kind of background mortality, from, the mortality related to recurrence of use, something like an overdose, etc. The same exact thing is going to happen in our PRSS group, except we also need to stratify that further. That's why it wouldn't all fit on this slide. We need to stratify that further because there's some proportion who actually are retained all the way through 1 year or successful completion of long-term peer recovery support services. And then there's going to be some proportion that don't go all the way through long-term PRSS, that drop out. And we kind of re-enter the dropouts back into the normal risk pool, this normal treatment as usual risk pool. And let's talk a little bit more about how we model that here. Oh, I'm sorry. And then this is our treatment as usual group up here and our intervention group down here in blue. And here is, oh, I hear that my video is lagging a little bit, so I'm going to go ahead and turn my video off so that's not distracting, okay? So here is what that looks like in a little bit more detail. We have, as our cost of the intervention here in green, we have the cost of peer recovery support services episodes for 1 year after treatment. And what goes into that, of course, is going to be peer worker pay, and then the service utilization for the participants, so how much peer services they're receiving. Then we have some portion who is returning to chaotic substance use, to active SUD, even after getting long-term peer recovery support services. There's another portion among people who drop out of peer recovery support services who might also return to active use. There's also some who don't, right? And then we know that only about 10% of them in any given year are actually going to get specialty treatment. And so then we just calculate the cost of kind of that group needing another round of treatment if they do. We then subtract out averted medical costs. This is our health system perspective. So we're looking at averted medical costs in this one, and we'll look at a couple other things in the societal view. We'll look at that in a second. Similarly over here, this is our treatment as usual side in blue. We're going to have some portion that returns to active substance use disorder and gets treatment again. So again, only about 10% of that group. And then we have averted medical costs here too, because again, treatment is effective. So there's going to be some averted medical costs on this side too. And in our effects, we looked at 2 different types of effects. We looked at QALYs. Remember, we always need to at least look at QALYs. And then we also looked at the number of people in recovery at 3 years. Why not right at 1 year? Because we want to see the durability of the intervention. Also because long-term PRSS, well, you might be freshly graduated from long-term PRSS at 1 year, right? So how much is that really telling us if about the immediate effects of kind of a longer term intervention? We might want to look at the durability of those effects over time. So instead we look at the difference in number of people in recovery at 3 years. I'm sorry, and then QALYs, that is also giving us a sense of durability over time because it's quality adjusted life expectancy difference, right? So it's the whole lifetime, and we're just adding up the difference in the number of years that it adds to people's entire lives. So it's kind of a long-term perspective for both of those. Okay, and then our societal model is very, very similar. except we're also adding in participant time. And instead of averted medical costs, we're looking at averted societal costs. We actually, medical costs are not included and productivity is not included because those are kind of accounted for already, you know, over here, and then productivity to some effect is already kind of accounted for in QALYs. Part of your quality of life is kind of this idea of, am I able to productively engage in my normal activities, right? Okay, so that brings us to the end of the part where we're giving background. Now we get to actually dig in and get our hands on the calculator. So you can feel free to scan this or just type in this URL. I'm going to leave it up for a few seconds so you have a moment to do that. It is web.sph.uth.edu/CEA, and the QR code should also take you there. Okay, I am going to pull it up now on my end. If I can, there we go. All right. I apologize. I think my computer is frozen. Nope, maybe not. Sorry, I apologize. 1 second here. Yep, my computer is frozen.
Let me see if I can pull it up real quick.
Okay, if you're able to take over sharing, you can pull up the screen. Oh, wait, okay, I think I might be back, maybe. Okay, are we back in business?
Looks like it, yes.
Fantastic, okay. And how is the size? I can zoom in just a little bit. I think there was just too much going on with the presentation mode and then also trying to open up a browser. So, so here is our calculator. Let me give you a quick, like 10,000 foot view walkthrough before we dive into the individual inputs, okay? So you'll see that it's got these 3 tabs across the top. The first one is peer recovery support services. The second is bystander naloxone distribution. And over here we have additional information. Eventually we will be putting up a tutorial and some other helping information. We will also include a link to this webinar. So this background information will be handy here as well. We do welcome any feedback, so please feel free to reach out to us at our email addresses. And then each of the 2 calculator components has an option to enter default values, to clear or submit. Otherwise, each field takes in any user-generated input. Only a few fields have some kind of limitation on what you can enter. You'll see that here there's a limitation as well, but not here. And we have the same option for default values and submit. Okay, so that's the 10,000 foot overview. We can work briefly through the PRSS calculator tab, and we'll just do a quick walkthrough and demonstration. The inputs here are how many people served. So that is in any given year, kind of what's your average yearly PRSS participant figure. So the default value that we used in just kind of setting this up was 1,000. That would be a pretty big recovery community organization. So let's put in maybe, let's say 200. What percentage of participants are retained to 1 year or to successful completion of long-term peer recovery support services? Sometimes people might be completely done and, you know, in a great place at 6 months or 9 months, right? Sometimes they may continue PRSS for years. So whichever kind of is first, 1 year or to graduation. So let's say I retain about 75% of the people who sign up for long-term PRSS actually keep coming back. And then at the time of graduation or 1 year, how many are still in recovery? Let's say about 80%. Our program's doing pretty good. Our average age of our participants. The average age that we use as kind of our default value is 38, but you could enter in anything from 20 to 54. Our calculator just can't quite handle values above 54 or below 20. So if you've got maybe a more youth-oriented program, unfortunately, we can only handle as low as 20 right now. But let's see what that looks like if our average age is 25. And then average number of engagements. So how frequently are they meeting with their peer worker during that time that they're engaged? So let's say maybe we've got about an average of 100 engagements, and then the length of each of those engagements. I also might want to include, you know, any paperwork time that my peer worker has to complete after each engagement. So let's say there's a solid 15 minutes of paperwork, and then a typical engagement is about 35 minutes. So we can enter in 50 here. And then what's our hourly pay? So the default value here, that is that average is actually estimated from wages across the country, but it's also averaged against reimbursement rates under Medicaid. And there's a huge range of variation for those. That's actually kind of what is dragging the number up a little bit. And you know, it may make sense for your organization to include any fringe value that is associated with that. So if there's, you know, a fringe rate on top of the hourly wage, you know, that might be the number that makes the most sense to enter for your organization. So let's say I'm going to enter 35 an hour, okay? So then we can hit submit. And results also have 2 tabs. We've got a societal perspective tab and a health system perspective tab. And we've broken out a lot of information. And let me walk you through how it's organized. Up top, we've pulled out averted cost to society, and we put that in terms of per person averted cost to society. We've also got kind of the total quality adjusted life years added by your intervention, also per person, and the total number of people in recovery in your program who wouldn't be in recovery if they'd only gotten treatment alone. And then we get down here into our ICERs. Remember, that's our price per ounce kind of style result, right? So we have a negative ICER for quality adjusted life years added and for people in recovery. And we have here in words, in plain language, is it cost effective to each of our willingness to pay thresholds that we set? We've got the 50,000, 100,000, 200,000, and then compared to the cost of another specialty SUD treatment episode. We also ask the question here, is it cost saving? So is it the right kind of negative? Remember, there's a bad kind of negative and a good kind of negative. And it just tells you yes or no automatically as part of the calculated results. It also gives you some context. So here in this nice little gradient panel here, we have a comparison of the cost effectiveness of your intervention to the cost effectiveness of other interventions that you've probably heard of that, you know, may actually, I apologize, the Zoom makes this a little bit funky to read, but here we go. Things that you've heard of and things that are generally regarded as a good idea, right? So things like lung transplants, things like dialysis, treatment of hypertension, antiretroviral therapy for HIV/AIDS. So this triangle here will move and show you the cost effectiveness in relation to these other commonly accepted interventions. And so you can play around with, you know, what are some of the tolerances? If I want to pay our peer workers $100 an hour, Is it still cost effective? Sorry, well, hopefully my computer hasn't frozen again, but but you'll be able to see it change if it's not as sensitive to that value. So if we put in like 1 million an hour, then you're going to see it move finally. There we go. So now it's not cost effective. If I start paying 1 million an hour, that's not going to help. I tab over to my health systems perspective. Let's set that back to 35. And I get, a kind of a similar set of results laid out in the same format. Instead of averted societal costs, I've got averted medical costs, but then otherwise I have kind of the same set of results. My ICERs down here, the plain language responses, and then kind of my contextual little triangle indicator here. And you'll see for the health systems perspective, okay, it's not negative, but it is still cost effective according to all of our thresholds that we set. So that's great. So I am going to turn things over to Marnie now to walk you through the naloxone portion. And just let me know when you need me to scroll.
Thank you, Sierra. The naloxone portion is it's a simpler model, much simpler than PRSS because it's a point in time. It's somebody has overdosed and you want to administer naloxone to reverse the overdose in that moment. And that's why it's a simpler model. It's just a one and done interaction. So Sierra, would you mind just clicking default values here? Thank you so much. So this again assumes that 20% of opioid users have naloxone in their possession, and the cost, this is for nasal spray, this was $68. I know it's varied and actually in really short supply right now. So $68 was the going value back in May. It's dropped down to $47. But if you scroll down, you can see the incremental costs with nasal spray. And this considers the likelihood of overdose, the likelihood that naloxone is present, the likelihood that it's administered, the likelihood that EMS is called, the likelihood that they're transported to the hospital, and then what those costs are. So the cost of bystander naloxone distribution, if naloxone is present, $887 versus treatment as usual, which is treatment as usual for this case is 911 is called, and paramedics come and administer naloxone and transport the patient. So the cost is cheaper without bystander naloxone, $603, a difference of $284. But then when you consider the quality adjusted life years, then you can see the ICER under incremental effects is $2.74. And again, we're comparing this to $50,000, $100,000, $200,000. Is it cost effective? Obviously it is. Cost effective $2.74 is much smaller than any of those threshold amounts. We have the same comparison on the right side of the screen here to show you how it compares in terms of cost effectiveness to other interventions. And then most importantly, again, with naloxone, what we're most interested in is saving lives, and a bystander naloxone distribution program over 1 year. This is assuming again, that 20% have it, and I think that assumes 1,000 kits are distributed. That would save 6.7 years over 1 year and over 19 years over 3 years. So obviously it's a cost-effective intervention and it saves a lot of lives, and that's the naloxone calculator. Thank you, Sierra.
Okay, thank you. Well, I think we are just about ready to go back to question and answer at this point, but I did want to put up our slide with our link to a feedback survey. I'm going to stay out of presenter mode so my computer doesn't freeze again, but you should be able to scan that QR code or visit redcap.link/calculator. And then also feel free to email any of us with any feedback you might have. And I'm going to turn it over to Dr. Brown for questions.
Yes, so there is if you have any questions, put them into the questions box. We have a couple here already. Let's see. The first one is, well, we have a few. What was the most challenging or surprising thing that you encountered when developing the calculator?
It's a good question. There's a lot. There's a lot that goes into it. I think a very pleasant surprise was how insensitive the calculator was to changes in peer worker pay. I think arguments around efficiency of the intervention are often invoked to, not pay people well or not pay people more. And, we can certainly, at least the balance between the resources in and the good stuff out, that balance can be maintained even when peer worker pay is substantially raised. So it certainly takes away that concern when people are looking at increasing peer worker pay. It's been an issue in peer worker retention just totally across the country, and so it was pleasantly surprising to see that how insensitive here being a good thing, it can tolerate a pretty high increase in peer worker pay before it starts to be inefficient.
Can I jump in there with
Sure.
what I found to be most challenging was the lack of data that's out there on overdoses and how to get the numbers and how many it's how to track overdoses. And so I know there are some projects going on right now, research projects in Texas that are trying to track down that data, and I'm really excited to see that. But I would think that was one of the biggest challenges. And then the surprising finding was I was updating this based on a study that was done in 2013, and naloxone is so much more prevalent now and so much more widely known among people who use opioids, and it has changed dramatically the transport numbers, the people who refuse transport to the hospital because they know naloxone works and they rely on it, and they know that they don't need to go to the hospital because they've gotten their overdose reversed. And so the numbers are strikingly different from 2013 to now.
Okay, great. Yes, I think the next question basically is the calculator for community groups or individuals. And I think individual. I would just throw out. I mean, individuals, you should just get treatment and not worry about whether it's cost effective. So it's really, we were thinking about community groups. I don't know if you guys have anything to add.
Yeah, I think so definitely for organizations to use, like a recovery community organization, a lot of them are engaged in exactly these two interventions, many others as well, but this is definitely something that both of those groups do. A harm reduction organization might also find the bystander naloxone piece of the calculator really useful. But then people, it can be useful for individuals too, in that an individual who wants to see some of these resources in their area, who wants to distribute naloxone on their college campus, any individual advocate may find it useful to advocate for the adoption of either of these two types of programs where they already are, if those things don't exist yet.
All right, and it says, would it be possible to include the range of values that can be used in the calculator? And they're particularly interested in the average age limitation for the calculator.
Yeah, the average age thing will it's in the helper text in the calculator, and then it will also give you an error message and let you know exactly why, like what the range is if you type something in outside of that. So that's really the only one that's particularly picky, and I think the naloxone one maxes out at 80% because it assumes a background of 20%. So, but we know we need an error message on that. That's a change we know we need to make. I also will say, I know we don't have our parameters listed up there yet. That is something that we hope to have a link to soon.
Guess maybe we could do one more. I've got that we're pretty close to one. Let's see, what's the next one here? Okay, one more question. Okay. How do you control for non-opioid overdoses, which are growing rapidly?
That's not in the model. The model's based on overdoses that can be reversed with naloxone, and otherwise they're not controlled for.
Yeah, I mean, I would just also say that we've got, there's regular mortality. So, you've got that's in the model. So it's not like we're assuming people who are not using opioids live forever, so you can die of other things. But yes, we don't. And so to the extent that they would be included, non-opioid overdoses included in that, you're right, since that's new, it's probably not in our model. But as we go forward, I'm sure that it will be. Okay. Okay, well, looks like we've covered our questions. We're running out of time. Thank you for attending. If you have any additional feedback, our emails are there. We'd love it if you gave feedback through the RedCap link as well. We will try to incorporate this. This is kind of like we're the first model year of a car. I'm sure that we'll get better data over time and all sorts of things. So thank you.